For those that don't know me, I'm a clinical pharmacist at Hutt Hospital, and I've also am one of the few small cohort of pharmacist prescribers here in New Zealand. And over the course of the training to become a pharmacist prescriber, and one of my current scopes now is to be involved with anticoagulation. Back during the training years, it became to light that there were quite a few problems with the warfarin management, and particularly communication between the primary and secondary care interface, and that's partly what I'm going to try and be talking to you today about, some of the initiatives that we've come in and put into practice, and how it could be translatable to other DHBs if they want to put it in place. As we know, warfarin was traditionally managed by the GPs or a suitably trained nurse in the GP practices, and there are plenty of standard nonograms available for management of warfarin according to your INR test. But in 2010, some of the community pharmacies started a pilot to become a CPAM, which means Community Pharmacist Anticoagulant management, and there are now currently 5,000 patients in 136 pharmacies nationwide having their INR tested at their community pharmacy. There are 12 community pharmacies here in the local Wellington Regional DHB, and that includes the South Wairarapa, and they provide a point of care INR testing. So they will, on a predetermined day, go to their pharmacy, have a finger prick test, the INR test, the test strip is placed into the machine, and the INR is then looked at, reported through online to INR Online. They have a standard series of questions that they ask the patients regarding changes in medicines. Have they missed doses? Have they had adverse effects? And their new INR testing, warfarin dosage is then given to them, and they're told, please come back for another INR test on such and such a day. But we ran into problems because the INR results weren't visible through our standard electronic reporting levels in the hospital. So patients would come into ED, they'd say they're on warfarin. The admitting registrar would look in the regional lab results or the local AAT laboratories, as it was at that stage, and they couldn't find any INR results. What's going on here? Well, who's managing what? How stable has the INR been? Oh, we go to the local pharmacy. Well, it's after hours, it's on the weekend, the pharmacy's closed. They can't get any information that might be relevant to what has been going on in the recent past with their INR history. So we also found that there was no easy identifiable place on our Concerto system that would identify these patients as being monitored by the CPAM rather than their GP. Conversely, the CPAM pharmacies weren't necessarily aware that their patients had been in hospital. They weren't necessarily aware or notified that the patients had been discharged from hospital, or what their current monitoring plan or when their next test was going to be. They might have been made alerted to the fact because the patient brought in their discharge prescription, but not all patients who had their discharge prescription dispensed, that same pharmacy might not be their CPAM pharmacy. There's only 5 in the local Hutt Valley, so there are people that travel to their CPAM. So they're not, the two systems for dispensing and INR testing aren't necessarily linked either. And also those CPAM pharmacists felt that they were a little bit isolated. They didn't know anyone in the hospital apart from perhaps trying to contact the prescriber of the discharge prescription, or even if they didn't have a discharge prescription, if they were running into problems with something of a plan that was organised through the hospital on discharge, who that they could potentially ring. So you can see there's lots of holes in the system between both ways. So during the course when I started looking at it, I actually went around a lot of the CPAM pharmacies and asked them, well, what are some of the problems that you're striking, and how can we get around some of these problems? And we made a list to try and improve that transfer of communication and provide them some support. But also, while I was talking to them, it occurred to me that they had a good system of monitoring, but were they really looking at how well were they doing for their patients at the same time? So could I help them set up an audit process that they could look at their own services that they provide their patients and find out these problematical patients and potentially prevent some of the adverse events happening and improving the patient's care. And the last point was, could we set up a peer support group for all these pharmacists? Some of them have been doing the INR testing from the pilot, and some were still coming in on the new contracts that were still being awarded through the DHB. And how well supported were they, or were they still working in silos? And were some of these communication problems similar to all of them rather than just isolated cases? Well, I had some challenges because there was no budget to do any of these interventions. And of course, it was during my own time, my own spare time, during my working day, how I could get about some of these things. And within our hospital, we've got multiple information service user groups. There was the alerts group, the computer users group. If you wanted to change a discharge summary, it was a different group. So there was a whole lot of different, even within the information systems, that we had to try and work around. And some of them the changes to the domains weren't as easy as some of the others. So they said, well, it's going to be put on a priority list, you'll have to wait. And it'll be put on the ideas board, then after a while it might make the to-do list, and then it will be prioritised through the to-do list. So we had to wait and see how easy some of this was going to be. I had done a few little basic audits beforehand, so I actually went armed to talking to a few of the clinicians about the possibilities of where we had some holes and how patient safety could be compromised by not having some of this communication going in both directions. And there had been certain couple of cases reported back to me that a patient had been discharged from hospital, required INR monitoring through the CPAM, which was identified as the CPAM, but they didn't actually go and have their INR monitored, and they turned up on the original previous next testing date, and they had already had experienced some adverse events, and at least one of them had gone back to hospital because of the adverse event. So keeping them in the loop was very, very important. So yes, as I mentioned before, some of them were easy to fix. I did actually know a lot of the contacts, having worked at the hospital for quite a while, so it was, once I knew the appropriate people to approach, it was easy to have quite good one-on-one conversations with them. Once we did make some changes, I actually used one pharmacy to trial those changes to see whether the interventions that we made actually worked for them, and then maybe change things, and then demonstrated it to all of the CPAM pharmacies, say, hey, we've got the system set up, you can use this now. But equally, when we made changes within our own secondary care system, we had to educate the users that this was happening and that, please, we want these new things utilised to help the patients remain safe. After that, I did actually set up that audit process for them and establish the support group as well. I'm not sure how many DHBs here used Concerto as the discharge or the electronic record system, but on our discharge summary we have two sections. That one says orphan on discharge, patient initiated, or there's been there's been changes made to the dosing while there, or there's another one that says patient admitted and no changes to dose. But the first one is quite important that we try and educate the doctors to use for every patient that has been in hospital, that has had warfarin initiated, has drop-down boxes. But one of the changes we had to make was that here, that the CPAM wasn't on our original drop-down box. So if the house surgeon's doing the discharge summary, it's now, community pharmacy, are they there? Please notify them, because actually they are going to be the ones that are actively doing the INR testing. It's important that they get notified that there is perhaps potentially a need for an earlier test than expected from their records. They also have another prompt in that on our warfarin chart. I try and encourage all our pharmacists, if they know that they're a CPAM pharmacist, to write it on the top of the warfarin monitoring chart. So when they're doing the actual discharge, they're looking at the warfarin dosing history, that it's actually there in front of them. So it's another active reminder that it would be pertinent to give them a call. And this is just a screenshot of when they've put in the dosing history. We actively ask them to try and put in as good a history as possible. So the patient's homepage, when it originally looked like, there was no indication of this patient was actually being actively managed by a CPAM. But approaching the alerts group, they very kindly let us add an alert so that now we can, when the patient's first brought up on there, it's quite clearly identifiable that if they require further information around their warfarin monitoring, that there is the name of the pharmacy and a phone number for them. And in clinics, the consultants actually find this quite useful, that they can just pick up the phone and quickly get any further information if they might need and get it faxed through. The downside of this alert, of course, is that it does have to be updated. It has to be put in manually and deactivated manually, which does get done. The third thing that I did, and this actually took a lot longer because it had to be actually involved changing an IS domain, but the principle was that if the INR test result that went to INR online at the point of care got emailed to the GP at that time, was there any reason why it couldn't get emailed into our Concerto system at the same time on that day at the time of testing? And it took maybe 18 months to 2 years before it actually made the priority list for IS domain change. It actually turned out to be very low budget, and once they got the approval to go ahead, it was all done in like 2 weeks flat. But as you can see here now, the format's changed a little bit since I've done these screenshots, but it says CPAM INR online. When you click on it, it will drop down, give you the test result, give you what the recommended dose was going to be for the next until the next test, how much they were to take, and any other notes that they might want to put in there. And it's clearly available 24/7 in the middle of the night when the pharmacy's closed. So as I said, the 6-month alerts have to be added or deleted, so this is manumatic, unfortunately, and I ring the pharmacies and ask them to email their current lists in, and I update all the new ones. They will tell me occasionally the ones that have completed their courses or no longer on warfarin. And also the alerts committee email me, please check these people out so I can deactivate the ones that have cross-reference them as well, so that system is in place to try and keep it up to date as possible. The community pharmacies in the Hutt Valley also have they've signed the security waiver, the security agreement, so they actually have limited access to our concerto system, and they can actually look up the discharge summaries for their patients through the NHI, and so they can read that discharge summary for themselves and see what the warfarin management plan will be. And that's they find useful, particularly if they've had the phone call to say your patient's been in hospital, and then they can read when the next INR test is due, and if they miss that by 1 day, whatever, they actually they often do actively call the patient and say, we're aware you've been in hospital and the plan was to have an INR. Are you able to come in and have that test as the plan? And the other thing they can do also is set up their homepage when they log in. If they talk to our IS services, they can set up their homepage for particular GPs, and it'll highlight all the patients that are for that GP that are in hospital. So they can quickly look to see, if they go on there, they can log in and say, oh, that's a CPAM patient, they're in hospital. I don't think they use that function as often as they can, but they do have that function available if they want to. The CPAMs are encouraged to order that practice. We set up a good template for that one that we trialled it with. I know their time constraints, they're very busy people, and I'm not sure exactly how many of them do that, but the problem solving that they did identify with some of their patients certainly helped keep their patients safer by more routine INR testing than they were frequently having. And they use a variety of different techniques to remind their patients that they were due a test. Audit of discharge summaries and prescriptions, I've just completed another one of those that I had done probably 5 years ago, and there is a variety of completeness would be the word. So there's still plenty of we've got a new cycle of house surgeons starting in about a month's time, so that's always an opportunity that we use to educate them on the importance of completing this discharge summary as much as they can. The regional peer support group did get established, and all the CPAM pharmacists were invited, and it just provided them an opportunity to talk to secondary pharmacists, the provider arm, do some troubleshooting and talk about problems. And as I said, an opportunity for the people that had just had their contracts and they just started doing their INR testing on how to go about some of the problems. That has been fraught with a few difficulties, partly because it is regional, so people from Kapiti, Waikanae, South Wairarapa, Wellington were all meeting in the Hutt Valley, and there were other commitments with families and professional meetings and Unichem meetings and all sorts of things, and it, unfortunately this year has not been as successful as it has in the past, but they still do have a chat group and a Google email list, so if there are problems they can still chat online if they want to, and they've established those links so they can always pick up the phone and chat to people and so what's your problem here? So that sort of completed all about 2015, early 2016, and then there was sort of, well, if this works successfully in Hutt Valley, why can't we have it in Wellington? And that was some of the talk that was coming through the peer group is, well, you've got these lovely computer things going on, and about the same time all the information services between the 3 DHBs were all joining, so everything got put on a hold. But this year, I think it was early this year or late last year, Wellington community CPAMs now have their INRs linked into Concerto through the Wellington portal, so that has been established, and I know that there has been some talk about the Wairarapa as well. So it's an ongoing thing, and it's possible, and when the IS department looked into it, they said, oh, that's not as difficult as we thought it was going to be. We have had a few hiccups. There's the occasional patient, I get the occasional email from a consultant to say, I can't access this person's INR results, what's going on, they're CPAM. And it's usually just a mapping problem. The GP hasn't been mapped properly to INR online, and the IS department fixes it for me quite quickly. And once they've sorted out what the original problem was, it's usually the same problem for every patient. And the other good thing too we've had over the last few years is shared care has been made available to us. So if for some reason there isn't an INR online result there, the shared care record, the GP record, still is now available to us, which wasn't when we were originally first starting to do this. So there is a backup, although they don't give you the same history as necessarily as what the CPAM result would be. Yeah, so it's part of your interventions. Some of the high-level ones have been working really, really well. Some of the lower ones not so well. So it's an ongoing thing. We have the PML that Chris was talking about. We have our INR monitoring and dosing chart through all 3 DHBs. It's all the same. The junior doctors rotate through all the 3 DHBs. The chart looks slightly different, but the dosing nanogram's basically the same. So we have continuity of information for them as well. So we're constantly looking at ways we can improve things for the management of our patients.